and welcome everyone to the Race Academy webinar series, episode 33. What a fast time we've seen this year take place. I can't believe we're more than halfway now and on the run toward Christmas. I was informed there's 16 Saturdays until Christmas, so now's the time to pin the ears, put the pedal to the metal, and force the team to keep their heads high and motivated whilst we head into the festive season. We've got, while we're waiting for the last few people to sign on now, welcome to everyone from Australia and New Zealand. Of course, we love our Kiwi brothers and sisters. Everyone in the UK, Singapore, and Malaysia. So it goes to show you the topics that Professor Stubbs brings to our webinar series are very highly sought after. We've got a large amount of people here today, Michael. For those of you that don't know or haven't seen it already, feel free to jump on racedental.com and .au and go and check out Dr. Stubbs' previous webinars. We did have one earlier on oral cancer last year. So today we're going to be talking about ulcers that are non-cancerous. So Professor Stubbs, we do appreciate you joining us. Before I do jump in, I will ask everyone to feel free to ask questions, type them in the comments below. We'll ask them at the end in case Professor Stubbs does tend to answer them as we go, but we will address questions towards the end. And I'd like to take this moment to thank everyone who came along to our Race Aligners event down here, did a little bit of a lab tour. They're extremely successful evenings and everyone walks away with a gift. So when the next one comes up, please feel free to come on down and join us down here at head office in Castle Hill, Sydney, Australia. We are very appreciative for the people that come and join us and have a look at our facility. We're very proud of our workflows and the investment we've made to bring Race Aligners to the Asia Pacific region. There are some more exciting events down under. Feel free to stay tuned for the Returning Club evening. We'll be hopefully launching towards the end of the year. But won't hold you up any further. Professor Michael Stubbs, thank you for your time, and I'll hand straight over to you for Doctor. I get ulcers in my mouth. Where to from here?
Thank you, Matt, and welcome everybody, and thanks so much for your interest. I'm just going to pull up the share screen. So last year I gave a presentation on, screening a patient's mouth for oral cancer or pre-malignant conditions. This time I thought we might just talk about perhaps some more common things that you may see which are not neoplastic, but they're useful to know. And this is my headquarters in Melbourne in South Bank. Obviously, one of the things I do with my new centre is I do training fellowships for colleagues that are interested in learning a lot more about TMD or dental sleep medicine. And as many people who watch this know, we work with the Race Dental Lab as well, and they're really fantastic supporters of education. So let's talk a little bit about some differential diagnosis. We call it differential or diagnostic sieve. So trauma is going to be the most common example of causes for ulcers in the mouth. And I mean, here's the beauty. If you don't mind me saying, it's a fantastic image of the buccal mucosa. There's the tongue. You can see there's teeth. And in fact, to be very specific, there's a decayed tooth there. And that white change is what we call slough. It's where the patient has put an aspirin alongside the tooth. And as a result of that, the caustic action or the low pH of the aspirin has burned the tissue. So they presented with acute pain, not from the tooth, but actually from the cheek itself. And often what I do say to patients is, if you had a headache, would you put the tablet on top of your head or would you swallow it? And in fact, I think everybody would say, oh yeah, I swallow it. So, the reasoning for putting an aspirin on the tooth, I'm not quite sure of, but always ask the question, if you see something like that, it's usually very sudden, very quick onset, probably 12 hours, maybe a bit longer. Patient will come in quite rapid pain, and obviously looking at the teeth, they might divulge they did put the aspirin against the tooth. So it still goes on, even though fortunately not that often. Treatment is using chlorhexidine mouthwash, alcohol-free, and obviously considering some numbing agent, even to the point of Sepicaine, although it can sting a bit, but it actually at least numbs the area so they can eat. I mean, this is more common. We see these. This is a nice one of the tongue where it's been choked. I mean, this particular patient was during the course of chewing, and often what happens when we're eating, we sometimes talk, or some of us do, and without concentrating, bang, bit the tongue. I think the important thing about these kind of mechanical traumas, and this one again is a great one where the patient had a inferior alveolar nerve block. You can see from the shape of the teeth, this was a young patient. And even though the lip feels swollen, and we tell our patients, please don't play with the lip, don't bite with the lip. Some kids feel the need to do that. And in this case, that was a pretty nasty, painful ulcer at the end. Again, you can associate quite easily timing, onset from an event, and usually 7 to 10 days resolved. And so that's where trauma is, particularly mechanical or chemical, is certainly a common one. This is thermal. This is a great one too. Have a look at the hard palate. You can see we've got some white changes occurring on the palatal mucosa, but these erosions, the red areas, is associated with trauma. Again, how did I know it was a thermal burn? Because I asked the patient, and they would have attributed it to an event. Usually it's cheese, hot cheese on a pizza. And so typically you'll see the anterior hard palate gets scalded. This is an interesting one. This is one of my cases many years ago, where he presented with this very large ulcer. You can see it's quite indurated. Look at the white margins here. That's typically in something that's chronic, where the body's trying to heal. You'll often see these raised areas and the white changes, but it's obviously quite indurated, quite deep. And that was biopsied, obviously, because I wanted to rule out whether it was a lymphoma or whether it was squamous cell carcinoma. And in fact, it came back non-specific ulceration. And so going back into the history, this gentleman suffered a condition called OCD, obsessive compulsive disorder, and he would regularly treat this area with a toothpick, and he would pick it all the time because the gum never felt right. And so in the end, it was the picking of the gum tissue with the toothpick on a regular basis caused this to happen, which is what we call necrosis, compromised blood supply, and there was the impressive ulcer. Again, how did we know that? I didn't ask the patient when I saw it, do they pick their teeth? But I did ask, we got the result saying non-specific inflammation, and then working backwards. Again, something like this, the treatment is very simple. Topical chlorhexidine is always really good. Curacet's a good one, but also recognising the patient had other mental health issue, and management is obviously out of the scope of what we do. Kenalog's a good one. If you get any patients where you suspect trauma, this is something over the counter. It's quite gritty, but that's the reason it's positive, because the orobase is the gritty bit. And all you do is you say to your patient, get a cotton bud, put Kenalog on one end of the cotton bud, the other end dry the ulcer, and then just paint it on. It actually gives a topical effect, which means it covers the region. And usually with this low dose concentration, it actually helps resolve the ulcer quite quickly. Again, normal time frame for trauma, 7 to 10 days. Idiopathic means unsure, unknown. And one of the most common ones that you may see is called the recurrent aphthous ulcer. So aphthous meaning mouth, ulcer, obviously ulcer. And the fact that these occur in a frequent or regular basis is partly the history, therefore gives you the diagnosis. And so if someone that you suspect has an aphthous ulcer, the first thing is you want to hear the history, that it occurs certainly often. It may occur once a month, once a week. They may have had certainly onset as a child. And secondly, you want to know that it's occurring in different sites, not just the same site. So if you get an ulcer in the same site, you think local factors, and obviously one of them you may be thinking about is neoplasia. But obviously if you're getting ulcers in multiple sites, you think systemic, and you think genetic, particularly idiopathic, like in this condition, recurrent aphthous ulcers. And so usually there's a positive family history. So often you'll find when I speak to the patient, I'll say, did mum or dad ever have the condition? And usually one of the parents did, and grandparents, and they can often link it to numbers of other members of the family. And so the most common one is the minor form. And you can see in this photograph here, you've got this very shallow yellow-based ulcer. You've got the red margin, like a halo, they call it, all the way around. Again, look, this is on the edge of the tongue, so trauma-prone site. 80% of cases, this is what the normal presentation is. In these cases, again, minor aphthous ulcers, they usually resolve 7 to 10 days. So you could use your Kenalog, but your diagnosis is your history of the patient. In other words, the history of getting them on a regular basis. And also consider the fact that the immune system in the mouth is the same as the gut. And as a result of that, some patients who might have Crohn's or celiac disease can get ulcers, because what happens is you're getting malabsorption of iron or B12 or folate, and that compromises the health of the mucosa in the mouth and makes the tissues more vulnerable to trauma-induced breakdown. So someone could have, let's say, aphthous ulcers as a youngster. The condition often burns itself out. So when they get to about 30, they start to go into a bit of remission. And then when they get to their 40s, 50s, and 60s, they get much less to none. And it's a common phenomenon. And then suddenly someone gets a whole plethora of different ulcers all the time reoccurring. Ask yourself, what's caused the change? Is it medication-based? For example, sometimes anti-inflammatories can trigger it. Is it a deficiency in iron, B12, or folate? Have they developed any gut problems, such as Crohn's or celiac disease? These are legitimate questions to ask. And also ask the other question too, do they get ulcers in other sites of the body? I mean, as dentists, I know our specialty is the mouth, but you can say, for example, do you get them on skin or genitals, etc.? Now, clearly, if a patient says they get them on the genitals, it would be above and beyond to then have an inspection of that area, not our area of expertise. But certainly knowing that means you're dealing with something more systemic than just the mouth. The major aphthous, fortunately, is only about 10%. These really great examples here, look at that one on the left. Very large superficial erosion. Now, again, this is diagnosed based on the history. They would have a frequent occurrence. They tend to occur where they might persist for up to 6 weeks, and they heal with scarring. This one on the right-hand side is also an example of a major aphthous ulcer, and they're always greater than 10 millimeters in size. So the key diagnostic factors to consider for this is the history of recurrence, the fact that they're bigger than 10 millimeters, the fact they often heal with scarring. So sometimes you can have a patient literally where the uvula has been destroyed by the ulceration. For these type of things, we use topical steroids, and sometimes we inject a steroid into the base of the ulcer to help relieve the symptoms. Friendly advice, if you get a patient who's got recurrent aphthous ulcers, have a look at if they're using sodium lauryl sulfate containing toothpaste. I can't say enough how sometimes switching to the toothpaste for dry mouth or SLS free, making sure it's got fluoride, can be hugely beneficial, because the thinking is that when you're using the detergent-based toothpaste, which most of us do, it can predispose the mucosa to minor trauma, and trauma often is the trigger for this. Trauma can be one of the triggers to cause it. And these is called herpetiform. Now, again, this is the other 10% of the condition. These usually you'll start to find a patient, let's say in their 20s or 30s, no history of ulcers to begin with. It gets the name herpetiform, not because it's caused by the herpes virus, but if you have a look at this photograph here, look at all the ulcers here, little tiny ones, clusters. And what often happens is that over a period of a few days, you get these joining of these little clusters to form a rather large one, like you can see here. Again, it's recurring in origin. It's not because of the herpes virus. Again, the management is usually a topical steroid. And consider Kenalog as a useful tool. But also, there's some interesting articles. I put this one up because this was a benchmark paper, and I looked at the association. You know the old saying, you are what you eat. When it comes to this kind of condition, there are some associations with certain foods. So if I had a patient who had recurrent aphthous ulcers, I certainly would get them to do what we call a food diary. Now, what that means is everything that they ate or drank 24 hours before they got the ulcer, they write down, and you look for trends to see if there's any correlation. So, for example, chocolate, hazelnut, walnuts can sometimes come up. Obviously, citrus fruits because of the acidity. Interesting, eggs there, and sometimes gluten in a patient who's celiac. The interesting thing, I think, is that in doing that, we recognise the condition is genetic. We can't stop the patient getting it. What we're aiming to do is reduce the number of ulcers they develop. And so SLS-free toothpaste looking at a food elimination diary and ruling out if there's any underlying systemic contribution that's causing the increases in numbers is actually a really useful thing we can do in dentistry. And fresh versus processed foods. Betchet's is I just put this as an example, but when we talk about aphthous ulcers, if you can imagine a spectrum, one end is the aphthous ulcer, minor, major, herpetiform. The other end is called Betchet's, and Betchet's is where you are getting ulceration in other sites of the body, particularly the skin and the genitals. And you can see Betchet's was named after a Turkish dermatologist. Particularly, there's a predisposition in those Japanese males, and certainly people from Eastern Mediterranean and Turkish backgrounds. And it can vary. So they don't always get the ulcers in the mouth at the same time as they get them on the skin. But you can see here, for example, there's a photograph of a patient with Betchet's based on the history. And you can see they've got an aphthous ulcer on the tongue, but they often get conjunctivitis, the inflammation of the conjunctival membrane as well. And particularly, you'll see here I've highlighted soft palate and oropharynx, particularly. They can get them. And these are just some examples of the nodules that can form as well in this condition. So a patient will come to you with regards, let's say, to ulcers in the mouth, but suddenly you're having a conversation with them and they're saying, well, actually, I do have other issues such as skin lesions, and then getting them to their GP, to a dermatologist, most appropriate. The reason Betchet's is interesting, fortunately not common, is because it's the actual other major issues that coexist with that condition is why it's significant. Arthritic changes, or in other words, joint pain can occur, neurological, such as paralysis, but this is the big one, the vascular issues. In other words, the risk of getting thrombosis is quite high. So as dentists, I'm not suggesting you're going to tell your patient you've got Betchet's. But what you would do is if you suspect aphthous ulcers as part of your examination, you might ask the questions, do they have other sites of the body involved? And if they do, referring them to their GP is a very worthwhile exercise. And for those of you who love to know everything, and I appreciate you would, that's why you're watching these lectures, and subscribe to Race Dental. This is a pathogy testing, which is where what they do is they get a needle, which is they prick it with sterile saline, and within 24 hours you get this positive reaction. I took this off the web, okay, so it's not one of my patients, but for those of you who like to know how you can test for Betchet's, that's one of the ways they do it, but they also look at the history. When we talk about lesions or ulcers, let's say, that affect the skin and the mouth, there are some common ones that you probably will see even if you haven't recognised them. This one is one common one. Now, it occurs at about 4% of the population, oral lichen planus. That was a paper I published obviously a long time ago. And you can see here we've got some photographs. Now, these are some of my patients, but look at the dorsal surface of the tongue. Now, one of the things you'll notice is the white, smooth surface of the tongue, this superficial ulceration, and the fact that you've got loss of a lot of the papilla. Lichen planus can present like that in a plaque-like form, and it's very, very obvious that that would need a biopsy to rule out squamous cell carcinoma. But you can see the tongue. Then on the side here, you can get these little tiny erosions, red and white changes. And this is a very classical appearance we call the striae of Wickham. So when you're looking in the mouth, often you'll find this type of appearance down towards the buccal sulcus, usually adjacent to the last mandibular premolar teeth, 7s and 6s. And look at the white web-like patination and the erythema or red changes. Often it can be ulcerated. And again, oral lichen planus and an oral lichenoid reaction, in other words, is the difference, is that this, in theory, is that if you can eliminate the cause, the trigger, it will disappear. Whereas lichen planus, oral lichen planus, is called idiopathic, unknown cause, and it persists. The significance to us as dentists is that when you're examining a patient where you suspect they have oral lichen planus or an oral lichenoid reaction, biopsy is very important. And obviously, because with that diagnosis, the low pre-malignancy risk, it's about 3%, or in other words, 3 out of 100 patients who have lichen planus in the mouth, less than 3 actually, but out of 100. can develop squamous cell carcinoma from these lesions. The big issue as a clinician is that if you have a patient who's got multiple areas, cheeks, gum, tongue, you can't biopsy every site. Well, what we do is once we've got a diagnosis, we would review the patients, whether it be 6 monthly or 12 monthly. And as a result of that photography, and we can compare the mouth and make sure that there is no changes. And if there is, it's rebiopsied, just to rule out the low risk of squamous cell carcinoma. And, histologically, when we look at these down the microscope, the thing is the diagnosis is based on the fact that this is the epithelium. You can see that I'm moving my scribe. And this is the dense band of mixed, what we call lymphocytes and histiocytes. So they have this very intense band of immune cells reacting to the epithelial cells. Because remember, keratinocytes, epithelial cells, have a role to play in immune function. They actually present antigen to stimulate the immune system. And so when we look at these in high magnification, we often will see these little tiny clear cells called dead cells. And then the thing is they're called Civate bodies. And bottom line is the diagnosis of lichen planus is quite a classical appearance and diagnosed by the pathologist. You can see, look at this gingiva here. This is called desquamative gingivitis. What does that mean? It means the epithelial surface is lost. So you're looking at the raw underlying connective tissue. Now, obviously, this is not because the patient can't brush their teeth. This is because these erosions are extremely painful. Plaque builds up, which aggravates the problem. But the treatment is using a topical steroid cream, not another type of toothpaste. Desquamative gingivitis can occur in lots of conditions. Allergy, there is a couple of blistering disorders I'll quickly show you in a minute. Lupus, another condition I'll show you in a minute, lichen planus. And so it can be a variety of different reasons. But the point is, again, in this case, obviously referring off to a specialist colleague to have a proper diagnosis is quite appropriate. This is an example of fingernails involving lichen planus called ungual. And you can see these linear lines. Sometimes they have quite significant gouges. Again, if you're a patient, let's say, where you've got the changes in the mouth, you can have a look at their fingernails. You're allowed to do that. And obviously this is the skin. And look at these clusters. This is one of my patients, actually. That was their fingernail and that was the wrist. And they showed me, so I could use it in the paper I published just so patients can look at it as well and identify what lichen planus looks like on the skin. 1 in 3 people will only ever have oral lichen planus, but 1 in 3 can have skin and mouth involvement, including the genitals. And again, this pre-malignancy risk is the big one. And that's the reason why following the patient up is important, and getting a diagnosis actually based on biopsy is also very important. I mean, here we can see a fantastic example here of an erosion. Look at that erosion. You can see the red, very ulcerative type surface. You've got this intense white changes, which we would call striae. Often it burns or stings. The treatment of this is using a topical steroid cream mixed with an antifungal called Dactarin oral gel. And the point is, in this case, is the erosive form particularly is considered to be one of the risky variations of lichen planus predisposing to squamous cell carcinoma. So regular review. Smoking and alcohol is an interesting one as well. What that means is the patient in concern. Now, not every patient's honest. Some patients will tell you they're non-smokers, or they may indicate they're a non-smoker, but they only stopped a couple of months ago. But it's just having the conversation with them and seeing if, in fact, there are those coexisting risk factors that may or may not be relevant to the conversion of lichen planus into squamous cell carcinoma. And Hep C is an interesting one. It's a bit less popular, talked about now, but there was an association with people who had hepatitis C, particularly in the Italian and Spanish populations, and the incidence of lichen planus compared to those in other populations where there was no associations found, particularly the studies looking at the French and the English populations. They didn't find that. And when we talked about lichenoid reactions, when we talk about a drug reaction, don't underestimate the impact that medications can have on the immune system and therefore the changes in the mouth. And this is quite a busy slide, and I appreciate, like many of you, you might review this talk at another time when it's being recorded, but these are some very common ones. See this one here I'm highlighting, angiotensin converting enzyme. That's really, in other words, an ACE inhibitor, which is a form of blood pressure tablet. Friendly advice on this one too. I've had patients who have been on a blood pressure tablet for 20 years, an ACE inhibitor, and suddenly they get swelling in the tongue, swelling in the cheek. And, you say, is there anything new, anything different in your medication or your diet? And they'll say, no, I'm on the same thing. ACE inhibitors, even 20 years taking them, can induce suddenly this frequent swelling. So often you'll find in a patient who presents at emergency where they've got swelling in their mouth, particularly the tongue, and they're on an ACE inhibitor, you'll often find the recommendation is to change the ACE inhibitor. And they put them on a steroid, obviously prednisolone, to switch down the swelling. So just remember that one. That's a, dare I say, a pearl. And lupus is something, fortunately, not that common, but discoid lupus, which is an old-fashioned term, which is this form, and SLE, systemic lupus, can also manifest itself in the mouth. And I'd like to show you some examples. Now, again, these are not cancerous lesions, but again, you might be the first person that picks it up. So if you have a look at this one, for example, this photograph is not one of my cases, but you see the intense redness and look at the white plaques and changes on the skin. Now, in the mucosa, you'd be easily forgiven for looking at that and saying that's lichen planus. But when the biopsy is done, it doesn't support that. It actually shows that the immune reaction here under the surface layer of the epithelium is also occurring further down in around blood vessels. So again, don't judge a book by its cover. When you look at a lesion, this is where we all get into hot water. We start to pigeonhole. We look at a lesion and say, it's got to be that because it looks exactly like it. And they're the ones that end up becoming, dare I say to you, a cancerous change. And we can see here in the case, this is an example of SLE. This is a red kind of change on the facial skin. It's like a butterfly lesion. And lupus is wolf-like. That's where the name comes from. And you can also see here this dry, rather crusty lesion. And again, this is also an example of where the immune system is not just targeting the mucosa of the mouth, but also on the skin surface. And particularly interesting is systemic lupus, particularly females are 8 to 10 times more often going to have the condition than men, particularly in childbearing age. And the average diagnosis is about in the 31 years of age. So it's the childbearing range of women that are more likely to perhaps be those the population that are at risk of getting lupus. The significance of lupus, we deal with the mouth, but I tell you what, you can get dry mouth from the condition, the patient can, but they also can have lots of other autoimmune conditions. And systemic lupus really means that it targets other conditions like joints, cardiac, kidney failure or kidney function leading to kidney failure. And so again, the diagnosis in this condition is actually an imperative. And one of the blood tests we look for is called double-stranded DNA. And I put that in there because when we screen a patient for autoimmune antibodies profiling, we say connective tissue related ones, in other words, targeting skin, muscle and joint. What we're doing is we're just looking to see if they're positive for any of the antibodies, which may actually help explain their oral condition, whether it be dry mouth, Sjogren's syndrome, or whether it be ulceration due to lupus or other conditions like Hashimoto's. And you can determine this by doing a blood test. And so I put this one up here because that's an important one amongst the other ones, which is called anti-RNA protein one as well. But again, for most of us as colleagues who are general dentists, you'd probably be inclined to refer your patient to their GP and they'd be managed through a dermatologist. And here, look at the hard palate. Now, as a generalization, when I ever see something like that, see how it's very pink and scaly? That you do see in lupus patients. Now, again, it can occur in lichen planus, but again, a biopsy would be mandated to make the diagnosis. And you can see here, look at the gingiva in this image. There's the white changes around the margins, there's ulcerative or erosive changes, very shiny red. So it's discriminative gingivitis. Again, that can occur in lots of conditions, like lichencephalus being one, allergy being another one, but more importantly, lupus as well. And finally, I just thought I'd give you some examples of some blistering conditions as well. And pemphigus vulgaris and pemphigoid are two of the more common ones we see, where the individual's making antibodies against the attachment apparatus of the keratinocytes, the cells that constitute the surface of the mucosa. And the difference between pemphigus and pemphigoid is just simply the sites where the antibodies or autoantibodies are targeting. So in pemphigus, you can see here this incredibly ulcerated tongue. This is the ventral surface of the tongue. And look at that. You can see there was a blister we call blistering bullae. You can see it's burst, and there's another one here. And in my experience, certainly seeing patients like this, you know, they've got an incredibly sore mouth, and then we go in and numb them up and then have to take a piece of tissue. We do that because we want to do some special tests on it to see if we can give a diagnosis, particularly what they call direct immunofluorescence. And so when we look at the biopsy down the microscope, this is a pemphigus. Just to orientate you, this is the surface layer of the keratinocytes. But you'll see, in fact, that there's the basal cells along here, which is still attached to the underlying connective tissue. But within the epithelium, you've got these blisters where the attachment between the cells has been destroyed by the autoantibodies. And so that's one of the diagnostic tools that we can use to make the diagnosis of pemphigus or pemphigoid. So pemphigoid would present where the basal cells here are also lost. And so you'd have full thickness epithelium. But it's the direct immunofluorescence. Now, this is an interesting one. What it's done is they've used anti-human antibodies incubated with a fluorescein attachment. And using dark field microscopy, what they've done is they bind to the antibodies that the person is making against themselves. So in pemphigus, the target is all the way around these cells. And so that's how they know pemphigus. In pemphigoid, if I could just go back one, the attachment apparatus would be all along the immunofluorescence rather would be all along the basal cell layer only. And I'll show you examples. So that's the reason why we biopsy. We can make a judgment. Now, the significance of these blistering diseases is for the longevity of the patient, because they can kill the patient. This is pemphigoid. Pemphigoid, again, is an autoimmune condition. The individual's host antibodies are attacking the skin. The difference is you can get a skin version. So this is an example of a blister. Now, it wouldn't just be one blister on the skin. They might present with multiple blisters, and it's incredibly itchy. And so often patients will present with multiple scratched lesions on their abdomen, arms, backs and legs. And that's a classic in the condition pemphigoid. But look at the mucosa here in the gingiva. That is absolutely red raw. That's the loss of the epithelial surface. And again, desquamative gingivitis, loss of the surface layer. The cause in this case is pemphigoid. Pemphigus can present the same. Lichen can present the same. Allergy can present the same. So, you know, when one looks at the mouth, you can make judgments, but often the evidence of a biopsy or blood test or both is really important tools to crystallise that diagnosis. And in the case of mucous membrane pemphigoid, which is another form of pemphigoid, it just targets the mouth, but it can also target the genitals as well. And here we got a hard palate. This is an edentulous patient. But the reason I took this photo, look at these blood-filled blisters. So again, the diagnosis was a biopsy, and you can see, as I'll show you in a moment, that what the immunofluorescence showed. This is an example of the eye. So some forms of pemphigoid can also attack the membranes of the eyelids, attaching themselves to the conjunctival membranes, and you get scarring. And so pemphigoid used to lead to blindness, literally, because the eyelids would fuse together and the patient couldn't see. And again, usually you'll find in older patients this condition, and again, eye involvement can be involved, and also within the mouth itself. And this is an example of what it looks like down the microscope. So here we've got full thickness of the epithelium coming off the underlying attachment. And the reason is because the antibodies for pemphigoid attach and target and destroy hemidesmosomes, which is where these basal cells attach to the underlying connective tissue, and pemphigus attacks or targets desmosomes, which is where it allows the epithelial cells here to attach. And as a result, you get the blistering within the layer. This is pemphigoid, complete loss of the epithelial layer completely. And again, this is a great example of the immunofluorescence. Notice the fluorescence along the basement membrane. That's how the diagnosis is made, based on a biopsy and an immunofluorescence test. And I think finally, infection. We know the mouth is not a sterile environment. I mean, I know that's an obvious thing. When we take a tooth out, even when we do a biopsy, sometimes secondary infection is a common experience. And so that's the value of using, say, chlorhexidine mouthwashes, and the patient minimising or trying to attempt to keep plaque control to a bare minimum so that they can maintain cleaner tissues, cleaner site of biopsy or surgery. And so this one, thrush, as it's commonly known, is a great one. You can see here, this is a patient who was actually on antibiotics, broad spectrum, several weeks of penicillin, and boom. Now, with the yeast we call Candida albicans is the most common one. They are normally found in the mouth. So having what people call thrush, we would call it pseudomembranous candidosis. Why? Because pseudomembranous, this wipes off, and these all represent colonies of the yeast organisms, and underneath you've got a red raw surface, is that the yeast organism's normally there. But it's called an opportunistic infection because if you change the immunology, let's say a patient becomes diabetic, particularly if they're undiagnosed, they get dry mouth. Suddenly the saliva protection that prevents the establishment of the yeast becomes less and less. And finally, if they're on an antibiotic, for example, they use a steroid inhaler and they don't rinse their mouth out, you get changes in the microflora and the thrush organism will take hold. And so this is another one of the soft palate. Denture wearers especially are much more likely to have higher levels of yeast than a non-denture wearer. Smokers will have a higher level of yeast in their mouth than non-smokers. And also people who obviously have dry mouth. So they're risk factors you look at. So if you had a patient, let's say, who presented like this, they'd had episodes of this, no history of antibiotics, not using a steroid inhaler, not a diabetic, think immune system, immunocompromised. In the old days, and I can say that because I was around then in the early 1990s, one of the key indicators when patients used to get HIV led to AIDS was the fact that they would be developing extensive thrush in the mouth, candidosis, and shingles as well in young men, particularly in that time. And so, because it affected their immune system. So, think about these things when you see them. And I realise you would do a swab. For those of you who are interested, you can get these from your local pathology lab. As a dentist, you simply fill out the request slip, you put the patient's details in, and you do a swab, and it goes into the specimen that's sent off and they culture it. But you can also recommend treatment, and fungal lozenges are great. 10 milligrams 3 times a day for a good week, sometimes 2 weeks. And secondly, also consider the nystatin, which the patient can buy over the counter. 1 to 2 drops on the tongue 3 times a day for, again, a good 7 days is actually quite useful in clearing up the yeast. For those of you who are interested, with the yeast, what does it look like on a smear? This is actually a stained example of a smear from the mouth. These are called hypha, and these are called blastospores. And when you see in one of these smears the presence of hypha, they know, in fact, that the candida, the yeast organism, is replicating, growing. This is another interesting one, draining sinus. Now, I have seen a case like this myself. You don't see often. This patient had presented originally in regards to a non-healing ulcer on the chin. And the case that I saw, which is not this one, is where the patient had had 2 episodes of surgery excising the chronic tissue, and it kept continuing to break down. A radiograph highlighted large periapical area of infection relating to a tooth. So again, you know, sometimes these ulcers one can get on the face, always associate the fact that if there's any underlying dental origin, arguably pretty rare, but you know, rare things do happen. The primary herpes gingivostomatitis is an interesting one too. We used to see this typically in young kids. Now we're seeing it in older teenagers, adults, because of the way we live. We don't tend to get out in the dirt much, and therefore interactions with others and young kids is much less. Maybe kids don't spit on each other as much. But the thing is, you look at this mouth. This is a child, and what's the thing that you notice the most about this image? The multiple ulcers, both sides of the mouth, tongue, gum, palate, inside the lip. So these are the ones where a child suddenly becomes very irritable, tired. They may be dribbling because of the ulceration. It induces stimulation of saliva. Mum brings the child in. She says, I don't know what's wrong with him. He's got a very sore mouth. And you open the mouth, you have a look at this. Primary herpes is actually quite a common phenomenon. It's the inoculation of the virus, and it's the immune response, us, the host, to that virus, which causes this massive destruction. It's extremely self-limiting in most people. In other words, you maintain fluids, rest, but more importantly also paracetamol if necessary, but not aspirin in kids. You should never recommend aspirin in children under 12, especially with a viral infection. It's called Ray's syndrome, which is a change one can get in the brain, which has been linked to the use of aspirin in viral infection. So bottom line is paracetamol is always a good one, liquid paracetamol particularly, liquid Panadol. And this is an example I took of a mouth of an image where you can see the fiery red gingivitis. That's one of the cardinal symptoms of the primary form. So if you get a patient, a child, teenager, and they've got generalized ulceration, they're feeling really run down, they actually have the fiery red gingivitis, consider primary herpes as one of the diagnoses. And the management of this, particularly in patients where they don't have an underlying immune response, is usually rest. Obviously, those patients where they do have immune deficiency, they might be a diabetic, they may be a organ transplant patient, anything like that with a viral, they'll always have antivirals. And I've just put these down as examples. Valcyclovir or Famvir. Again, the patient's GP would organise that appropriate management. But really, for most people, it's about recognising and reassuring the patient that it will improve 10 to 14 days, pain control, so it could be paracetamol, just bed rest or soft food anyway, and maintaining to prevent dehydration. And Chlorhex mouthwash and gels, can't recommend that enough, keeps the mouth clean, particularly if they can't brush their teeth. And only those in patients where there's immune compromise. Again, in these are cases where you would send them to their GP. And we don't tend to see this anymore, fortunately, herpetic whitlow. That's where in the old days, before dentists used to wear gloves, and believe it or not, that used to happen, the patient sometimes might have had active herpes simplex, and under the nail bed in this case, they got a chronic herpetic lesion there, and it would often be very painful, often result in the loss of the nail. But the issue is that they'd get reoccurring lesions as well on the fingertips. And this one is where, when you get a patient who's got the primary herpes, often by the time you see them, the infectious part of this condition is gone. It's usually the first few days prior to the ulcers occurring, but making sure with kids, they don't rub their eyes, because you don't want to inoculate the conjunctival membranes with the virus itself. Because remember, it's saliva borne. And in these patients, and humans generally, 1 in 10 people will shed the herpes virus in their saliva, 9 in 10 don't. So once they've had the primary, that's it. The virus is stored in the ganglion of the nerves relevant to where the infection occurred. And of those cases, 40% of patients can get what we call cold sores, herpes labialis. And this is where the affected dermatome, that means the region of the skin where the innervation of the nerves, where the herpes virus is residing, they transfer down the axon, become activated, and the patient gets a classic cold sore. Now, these days, it's a really good treatment. So one of them is famciclovir. The patient can go into the chemist. They can buy a packet of 3 tablets, 500 milligrams each, and they simply take 3 straight away. And it's very effective, particularly in patients where they feel the tingling, the onset of the cold sore, and that's called a prodrome. So if you get your patient, let's say, who says to you, look, I get cold sores, I don't know why, I get stressed. Well, that's one reason. But windburn, sunburn, traumatizing the tissues can trigger it. But if the patient gets the tingling signs, just taking the 3 famciclovir, which they can buy over the counter, will often abort the ulcer, abort the cold sore developing. And again, Zovirax, everyone knows about that, I'm sure. It's something, again, patient can buy over the counter. It's topical acyclovir. The issue with this one is the patient's got to put it on regularly, 3 to 4 times a day for the first few days. Whereas with the famciclovir, the benefit of the tablets, they just take 3 tablets, that's it. And as we all know, people like the easy way out, so therefore, usually they go for the tablets. And finally, these are common ones you see typically in kids, Coxsackie viruses. Now, they're very highly transmitted by saliva. Typically, we see it in younger children, kindergarten, primary school age. And in this one, this is where the patient has little tiny ulcers, but on the soft palate and the back of the throat, not in the mouth. And they're multiple numbers. And it's called herp angina. And so in this case, again, no treatment is necessary other than soft foods, keep up the fluids, and paracetamol. The hand, foot, and mouth condition, which is another condition, is where the patients get all these little tiny ulcers. Have a look at these in the image. All these little small ulcers, but they also get these red spots on their feet and the palms of their hands. Again, it's very self-limiting, 7 to 10 days, resolves. No real action is required. But again, you might be the first colleague or first person that the patient goes to because the mouth's sore. They don't worry about the skin. And the shingles virus, which we all know about, the really important one about this is these days most people have immunisation. But for those of us who actually had the primary form we call chickenpox, we store the virus again. That's herpes simplex. It's called herpes simplex virus type 3. Chickenpox is the primary form. Herpes virus, I'm sorry, type 3. Chickenpox is the primary form. They get oral lesions, they get itchy spots, they often patients scratch. And again, it's very self-limiting. But 40% of patients who have the shingles virus, it flares up again, and it's varicella zoster virus, and leads itself to shingles. And that's the secondary form. And in this imaging here, which I've taken from another source, you can see here we've got these ulcers on the palate. Now, again, folks, if you get a patient, let's say they've got ulceration on a hard palate and it's absolutely unilateral. In other words, it's not both sides, just one side. Think viral, because that's going to be most likely the cause, particularly the varicella zoster, shingles, the herpes simplex viruses. Think viral. In this case, this patient's got involvement of the skin, and often they get the burning, tingling symptoms. Sometimes when shingles starts to present itself in the first 24 to 48 hours, believe it or not, their first primary presentation might be excruciating tooth pain. And that's because the nerves affecting or supplying the region of the teeth are affected. And again, monitoring the patient. If you're not convinced that it's a dental problem, reviewing them in 24 or 48 hours makes a huge difference. But once they start to get the changes on the skin, immediate referral to their GP to implement the famciclovir, the valciclovir, very appropriate. And the reason why it's important, and this is a great example of one of my patients actually, look at that. See how it's unilateral? All these clusters of ulcerations on one side. Think viral. This affected the greater palatine nerve distribution in this case. And when we think about shingles or oral involvement, always recognise the fact that the patient might use the term stinging or burning, and usually for say 1 to 2 days, that can be an indication it's a viral induced issue or cause. That the treatment of any antiviral ideally would be within the first 3 days. So if someone's starting to get changes on their face, or they're getting ulceration erupting, it's unilateral, trying them or getting them to see their GP to start antiviral, very important. And the reason is because of this one, post-herpetic neuralgia. Now, this is something where a patient has shingles resolved, the patient has stabbing, burning pain in the region, and it goes on for 6 months, 12 months, 2 years, 5 years, and ongoing. Now, typically we see that more in the older patient over 70, but the thing is, it's a very difficult thing to manage. So again, being proactive, looking at the ulcers and saying to yourself, in my diagnostic sieve, is it trauma? Is it idiopathic? In other words, they've got a history of recurring episodes. Is it related to an autoimmune condition like lichen planus, lupus? Is it related to blistering condition, pemphigoid reactions? And also, is it infection-based? So is it unilateral? Is it generalized? Is there any underlying systemic causes that are driving the condition? These things are really important. And I think, like most of you watching this, you would probably be of the view that if you had a patient with an ulcer and you weren't sure what it was and it didn't resolve in 7 to 10 days, I do appreciate you would refer it off to a specialist for a biopsy, unless you did it yourself. And on that note, I'd like to finish. Thank you.
Oh, thank you very much, Professor Stubbs. I'll jump straight in for the lack of time to the question. I think you may have answered it, but I'll ask it anyway. Professor Stubbs, you're obviously very experienced in diagnosing different types of ulcers. If we're unsure, do you recommend we immediately refer the patient to a specialist such as yourself, or should we swab for diagnosis first?
Well, what I would do is, see, swabbing doesn't always give you an answer, but what I would do is take a photograph, clinical photograph, so you've got a record of how it looks at the time, and preferably put a perioprobe next to the ulcer. Unless it's multiple, then you don't need to do that. If it's a single ulcer, you put a photograph with a perioprobe, and then if you review the patient 7 to 10 days, and always err on the obvious, which means consider things like chlorhexidine, topical therapy, really simple, keeping it clean as best as it can and from using the chlorhexidine, and soft food, etc. And then review the patient. If it's persisting after 10 days, then you'd refer it off.
Okay, look, that's fantastic, Michael. We are very short of time. I do appreciate you spending time with us. For those of you that want more information, or if you're not quite sure, this webinar has been recorded. Feel free to go back to racedental.com.au into the education component as of tomorrow, or maybe the next day. This webinar recording will be up and running. So feel free to take your photographs back to the webinar and assess exactly what Professor Stubbs has shown us today, and feel free to lean into this webinar in the future to get more information should you require it. Michael, congratulations on your new clinic. It's about time we get to see you in beautiful new premises.
I've got to get you guys down from Sydney. And folks, those of you watching this, I realise in Australia, unless you want to come in from overseas, you're most welcome to visit the new centre. It's a teaching institute that I've created where I will be also training dentists and doing mini residencies type training in TMD, mucosal if they're interested. And I really appreciate the opportunity to share the knowledge again. Thank you very much, Matt.
Well, thank you very much, Michael. The 89 people that join us today will all be down there tomorrow, so if you could put some lunch on, that'd be great.
I better get the catering then.
Ladies and gentlemen, thank you again. We hope to see you soon for episode 34, but congratulations. Thank you, Professor Stubbs. We'll see you all soon.
My pleasure. Thank you.